It Takes Balls is brought to you by our new sponsor, D's Nuts. Yes, you heard that right. If you've never heard of them, check them out at grabdsnuts.com. But warning, these are not your grandparents' peanuts. D's Nuts has really shaken up the nut game. They're gourmet, fun, and packed with flavor. Whether you're a fan of savory flavors like ranch, sriracha, or hot cheddar, spicy like ghost pepper, or if you have a sweet tooth like me, you'll like the banana pudding. D's Nuts has something for everyone. But D's Nuts aren't just about taste, they're about making a difference. For every bag, can, or piece of D's Nuts merch purchased using the coupon code NUTCHECK on grabdsnuts.com, you can save 10%, and another 10% gets donated towards supporting Testicular Cancer Awareness Foundation. So the next time you're craving a snack that's both delicious and meaningful, reach for D's Nuts. Because when it comes to supporting Testicular Cancer Awareness Foundation, it takes balls and it takes D's Nuts. Available at grabdsnuts.com, Amazon, and Walmart locations nationwide. D's Nuts, a delicious, healthy snack in a variety of fun flavors and making a difference one nut at a time. The stories shared on It Takes Balls are unique to the individual sharing. Always speak with your trusted medical provider for treatment options specific to you. Welcome back to It Takes Balls, presented by Testicular Cancer Awareness Foundation. Today we have a very, very special guest, and I'm actually going to have to read his credits here. So Dr. Sean Kern is a urologic oncologist at Murtha Cancer Center at Uniformed Services University and Walter Reed National Military Medical Center, Bethesda, Maryland. He's the program director of the Walter Reed Urology Residency. I'm running out of breath here. He's the founding director of the military's Testicular Cancer Enterprise for Survivorship, Treatment, and Investigational Sciences, otherwise known as the TESTIS program, a lieutenant colonel in the Army, and most importantly for us today, is a testicular cancer survivor. So Dr. Kern, thank you so much for being here.
It's a pleasure to be here. I really appreciate the opportunity.
So we mentioned all those credits, but I ended with survivor. So you are a testicular cancer survivor, but before that, you even trained at IU under Dr. Einhorn and his colleagues. So tell me about that.
I was always interested in urologic oncology, and we went through the interview process, and I really enjoyed the program at Indiana University. With the training that they give, and you get to form mentorship relationships with the biggest people in the urologic community, and especially in testicular cancer. So I did my 2-year fellowship, and I then went to Walter Reed in Bethesda, Maryland, and started practicing. And so it was a really good foundation that I got from Indiana University, with all the different cancers, operative, experience, and then also got to see a clinic with the medical oncologists, like Dr. Einhorn and Dr. Adra, to really get the medical oncology perspective of urologic cancers. So I feel really privileged to be able to have trained there.
Yeah. And, having been there with the experts and everything, all the stats. I mean, did you ever think that you would be one of the patients one day?
Never, especially testicular cancer, because I really thought I was kind of out of that age range, since it's typically in the 20s and 30s that the disease impacts that age group. And, sort of like when you're going through training, you sort of separate yourself from like the doctor and then the patient. And if things happen to the patient, they get cancers, and you're like, man, that's just really unfortunate for the patient, and cancer's horrible, but you don't really, put yourself in that situation of being like, hey, I could totally have this cancer. So, it was shocking, to say the least, to be somebody that is a urologic oncologist that does a lot of testicular cancer, that has an interest, a research interest, and a clinical interest in testicular cancer. And then I eventually get testicular cancer when I was 40 years old.
So let's talk about your journey with cancer. So I know you noticed it around Easter. Has it been now over a year?
It has. I just passed. I'm into year 2 now. I'm 3 months into year 2. But I finished chemotherapy July 10th of 2023. So I'm just past my 1 year anniversary of finishing chemotherapy.
That's amazing.
So
Congratulations.
far, so good. Yeah, I actually had my tumor markers drawn yesterday, so I'm always a little apprehensive about that. Haven't found out about it yet, but
Yeah. So around Easter, what was your symptom that you noticed?
I just had a painless testicular mass in my right testicle. I, routinely do self-testicular exams like I counsel all my patients. Anyone with testicles should be feeling and make sure there's no abnormalities. So it's just, basically pulling up my boxers one day, getting out of the shower, and I've felt something. And initially I'm like, no way, this isn't a testis mass. This couldn't be me, right? But it was really concerning, and I even had, I called my partner and was like, I think I have a testis tumor. And so this was exactly as you say. It was Easter weekend. I was traveling with my family down in Oklahoma to my parents' house, and I flew back the next day when we were scheduled to fly back. It was the longest flight ever. Young kids with the wife, a ton of anxiety, and I said goodbye to them at the airport and just drove straight from the airport to the hospital where my partner met me, and we walked over to radiology, got an ultrasound, and it's sure enough, it's a vascular mass inside the testicle, concerning for cancer. I got a CT scan of my chest, abdomen, and pelvis, and it was negative. And then the next morning, I had a orchiectomy. Um,
Yeah. So that was a quick turnaround.
yeah, and I totally recognize that I was fortunate enough to know everybody, and they were able to get me in fast. And it was interesting. The person in charge of the operating room actually called me and was like, "Hey, I know that you added on a orchiectomy tomorrow. We'll try to fit it in between cases." And I was like, "Hey, I'm the patient. It's not my case." But I'm ready to go whenever you tell me. And that totally blew his mind, thinking like, oh my gosh, like you're the patient. I just saw your name on the board, but I wasn't thinking you were the patient, not the surgeon. So it was obviously, it surprised everybody, like anyone diagnosed with cancer.
Yeah. Was it your partner that did the surgery?
It was. Yeah.
So like with TCAF, we talk a lot about like removing the stigma and everything. Was there any stigma that you felt about your partner operating on you, like with, testicles being taboo, quote unquote? Was that any concern for you?
No, no. I mean, he's a good surgeon. He's professional. I mean, I had another partner. They both did the case, and so I had full trust in him. But yeah, I mean, it was experiences that I never experienced, right? Like getting a scrotal ultrasound, like that was a little awkward, right? And all the gel on your scrotum and like all those things was something I had never experienced. And so I truly was out of that doctor mindset and just in a patient mindset. It's really surreal.
Yeah. So, do you remember your pathology?
Oh yeah, it was 98% embryonal carcinoma and 2% seminoma with LVI. So I was stage 1B because I had risk factors of LVI and embryonal carcinoma predominant. And I was able to, my partner was able to get the pathology reviewed by pathologists that do this a lot at the Joint Pathology Center. So the pathologists at Walter Reed and the Joint Pathology Center, which is sort of like the military central pathology consultative service that they also do civilian consultations too. So anyone that needs to get reviewed can always get it reviewed there. And so when they called me later that week to tell me the path, I knew it was accurate.
Yeah. And then you did opt for chemo, correct?
Well, that's a great question. So immediately my head's spinning. I'm calling everybody, all of my mentors, at Indiana University and throughout the country. And a lot of people recommended with stage 1B, my chance of recurrence or occult metastasis is pretty high, 40 to 70%, depending on the data you look at. And they recommended a retroperitoneal lymph node dissection. And then Dr. Einhorn and everyone else at Indiana was like, no, we should watch this. We should do surveillance. The chance of cure is the same if you do surveillance now. But if you recur, you're at a higher likelihood of needing chemotherapy. So and he wanted a close interval follow-up. So Dr. Einhorn wanted to get a CT scan in 4 weeks. So that was a long 4 weeks, like everybody. Recovering from the orchiectomy was, you get better each day, but you're sore. And then I got the scan. And it made my decision pretty easy because I didn't have a decision. So my scan showed cancer in the retroperitoneum, not pretty good volume in what we call the templates. So typically right side goes to the right side of the retroperitoneum, left side goes to the left side. I have a right-sided testicular cancer, but it was on both sides. And the lymph nodes weren't huge. The largest one was 2.5 centimeters, but there's probably 15 of them. And so I knew right then and there, surgery's not an option. Surveillance is no longer an option. And it was immediately to chemotherapy with no decision-making process involved.
Gotcha. Okay. So yeah, I mean, with all the other doctors' input, you said you separated yourself like doctor to patient. Did you use any of your own intuition in the beginning, or you strictly were following your doctor's guidelines?
I was strictly following the doctors that recommended what to do, and I knew I look at, and I've said this at our conferences, Dr. Einhorn is the god of testicular cancer, and he's done this more than anyone in the world. And if he says to do something, you say, okay, no problem. And so that was pretty easy. We had a conference call with my wife sitting next to me, and he really nicely outlined all of the risks, and same for Dr. Carey and Dr. Masterson, everybody at IU, right? We all had different, conference calls. And so that was pretty easy. And the decision to get chemotherapy was really out of my hands. And then the next decision was where to go, and I could have certainly gotten chemotherapy locally. I was not able to get chemotherapy in my hospital because it just happened to be that week. The hospital was changing over its medical record system electronically. And so they were not giving chemotherapy to anyone because they still needed to do the safety checks. And so I was either going to be seen by a civilian medical oncologist in the region, or I go to Indiana University. And so that decision was pretty easy for me because I trained there. I was familiar with that area. And the military, allowed me to go there. And so we got an Airbnb for 2.5, 3 months. And 3 days after my CT scan, I drove out to see Dr. Einhorn in person. And he's like, I want to do your chemotherapy. We should start today. So he literally had his nurse walk me from his exam room over to the infusion center, and I had my first day of BEP times 3.
Wow. Did you have any notable events that happened to you during chemotherapy? And then how does that impact your decision making when talking to patients of your own?
Yeah, so you can either get EP times 4 or BEP times 3. They both have for my risk disease. I was good risk, non-seminoma, and each regimen has its own risks and benefits. I was really, really worried about peripheral neuropathy, being a surgeon myself. And so, and Indiana University really prefers BEP times 3 for lots of different reasons. But BEP times 3, I'm getting a little doctorish, sorry, but BEP times 3, there's 3 cycles of the cisplatin instead of EP times 4, which is 4 cycles of cisplatin. So my risks of peripheral neuropathy, which would be like like numbness, tingling in my hands or bottoms in my feet, typically. Obviously, my hands were more concerning being a surgeon. I wanted to have less exposure of cisplatin, which can cause that. And so we did BEP times 3. During the treatments, I didn't have a lot of complications. Luckily, I tried to eat well, tried to sleep well, because your body's recovering when it sleeps. I still try to be active. So my first cycle is still trying to stretch and go for some runs or walk my kids or something like that in the stroller. And then, as it progresses, we could talk about that if you'd like, but as it progresses, that third cycle, I was basically just kind of walking and stretching, not doing a whole lot of exercises. But luckily, Indiana University had the oncology service has this health and well-being initiative that has its own gym just for oncology patients. And so I was able to even do 20-minute workouts, like light weights, or walk on the treadmill, or stretch and with a foam roller or some rubber bands and stretch out my muscles and stuff. So I felt like I was doing something, maybe getting the blood flow a little bit. And then I was able to do hand massage during my infusions, which was pretty cool. Which was nice to kind of decrease some anxiety, getting like a little hand massage during your infusion, sitting in the chair, right? And they say it can improve some lymphatic flow and blood flow and things like that. But I did have a complication after chemotherapy. I had a DVT, deep vein thrombosis, so a blood clot in my right leg that was pretty atypical in how it came about and how we found it. But that ultimately led to me needing to be on anticoagulation for 3 months.
Wow. What was I know symptoms for DVTs can be like swelling and heat. Is that what your symptoms were?
Not really. I felt a little like leg cramps, but it was in both legs and then in my arms throughout treatment, and that could totally be just from the chemotherapy. My right one was cramping a little bit more, and was a little bit more stiff, but I didn't have any swelling, no discoloration, no warmth. Obviously no shortness of breath or anything like that. That would be a concern of like blood clots in my lungs. And then after chemo, I was able to get back to running and doing some light weightlifting. And it wasn't until about 6 weeks after chemo that I then started to notice some swelling and some kind of discoloration, like bluish discoloration, just on like the outside front part of my leg. And then I called the medical oncologist at Walter Reed and told him like, hey, I probably have a DVT. This is really weird. It's it's different than the other leg. And so she had ordered an ultrasound, and sure enough, it was positive. So whether that was from the chemo or what, I don't know. I have to think it's probably from the chemo. I did drive from Indiana to back to DC, but I had compression stockings, and every hour I stopped and I walked around for 10 minutes trying to prevent blood clots. But it's probably from the chemo.
Interesting. Okay. So after your DVT, what were your next steps?
Just to get the treatment. So, I was on anticoagulation, which is a pill, and for 3 months, and then we stopped, and then I've been fine. I haven't had any symptoms. I even wanted to get another ultrasound afterwards just to make sure, and the ultrasound was negative. There was no residual clot left. So, luckily, I haven't had any issues with my leg, and luckily, I have no issues with my hearing or with no peripheral neuropathy. Been really fortunate with that. Hasn't had any issues operating or dexterity or anything like that. So far so good. And then it's just like what everybody does the surveillance. And so I had a CT scan during chemo. It showed the lymph nodes were shrinking. I did CT scan after chemo, which still showed nothing had grown and markers had been negative thus far. So I'm just adhering to the surveillance strategy that I'm supposed to be doing. And so far so good.
Amazing. So we're going to kind of segue into your professional life now, but I do still want to talk about your personal experience and kind of how that informs your decision-making for your patients. But first, let's talk about the TESTIS program. Was that something that you started because of being a patient and survivor, or is that just a coincidence?
Yeah, total coincidence. I knew I was always interested in testicular cancer after fellowship because I thought it was it's a really interesting biology tumor. It's really high cure rates. It impacts young men, and it's the most common cancer in the active duty military population. And so that I was already gravitated to that. And then I really wanted to have kind of like a central point for all military and even VA, if they choose, to have kind of like a standardized pathway for survivorship, for research, for even treatment, to basically having a system where we could set patients up for success. And so I was lucky enough, kind of pitched it to my leaders in the hospital, and they were able to give me the funding and, hired, thus far, we have 2 nurses and, we have a clinical database and some research protocols, and just kind of expanded this thing out involving medical oncology. So we have in-person appointments, and we also do virtual appointments. And I knew the military, unfortunately, patients are set up for failure, not by the military's fault, but just by the fact that it's the military. So people are getting deployed. People are being moved around to different bases. People's doctors are being moved around to different places. People get out of the military and kind of have to find a doctor. So I wanted to have some way where there's a centralized program that we could follow anybody. So wherever you go, we can still make sure you're getting up to date on your CT scans and your tumor markers. Or if your doctor leaves and you have to find a new doctor within that military hospital, that new doctor knows your care, knows what you're due next for, rather than just leaving it up to the devices of the patient remembering to call and getting their CT and their markers and their chest x-ray done. And then I also wanted to develop a system that would help patients when they get out of the military and go to the VA, that they have good continuity of care, that we could help them get their images loaded over to the system, get all their medical records loaded over to the system. And then we expanded out to the survivorship. So, placing an importance on behavioral health and fertility counseling and recommendations for multi-D, which is multidisciplinary clinic with medical oncology and infertility services, urology, pathology, radiology. So we have experts at Walter Reed, but if you're at a small hospital that may only have one or two urologists, that may not do a whole lot of testicular cancer, that don't have an oncology training at a place that has high volume testicular cancer, or pathologist doesn't see testicular cancer often, et cetera, they've got somebody to call. So that's kind of the impetus for the center. And then, about 2 years later, I'm also a patient of that center.
Yeah. It kind of sounds a little bit like you're kind of the Dr. Einhorn of the military, the way you're helping to coordinate everybody's care around the world.
I'm trying to just do what I can, but no, Dr. Einhorn, no one can replace him. But yeah, I mean, I'm constantly, maybe too much, constantly paranoid about people not following up, and not only does the military have potential to set people up for failure, but just the patient population, right? And we know 65-year-old guy with cancer is more likely to have treatment adherence, to go to his appointments, to get the scans, to be on medications they're supposed to. A 20-year-old that's got a lot of other things in their life. What's my job? What's my relationship status? How much money do I have? Do I have health insurance? Do I have kids? Do I want kids? That makes it hard to really pay attention to your cancer and do the follow-up you should have. And so I think that's an important thing that I wanted to have for the military and anybody, really.
Do you do like continuing medical education for military doctors? Because I'm going to use an example of a survivor from California. I don't think he was your patient. We have had some of your patients on here. You can't confirm or deny that, but I can. But Mike Sanders, a previous episode, he was stationed in Greece, where I think there wasn't like a big hospital system. I don't know if it was even associated with the U.S. military, but they kept diagnosing him with like a potential STD. So are you like working with doctors all around the world to kind of raise their awareness so that they are more keen to notice signs of testicular cancer?
I am. Yeah. And I think that's not just me, but I think any person that sees this disease, whether they're a medical oncologist or a urologist, we're always trying to promote awareness of testicular cancer, because it's most commonly presents with the mass. So it's easiest found with just screening, guys feeling their testicles. But I get calls and emails a lot about what we should do, or, hey, can you look at this ultrasound, or what kind of chemo do you recommend? So we try to be like a global support system for the military, and then through TCAF, I've got people that can reach out, and we can chat about different things from patient perspective, or my experience as a clinician. So yeah, we try to, and then we have our military meetings every year. That last meeting I presented on the TESTIS Center about what we do, who we are, what we can offer your patients, and showed them some data about improved follow-up and improved fertility counseling, improved behavioral health access. So yeah, I'll trying to leave the system better than when you found it.
Yeah, amazing. You mentioned testicular cancer being like the most common cancer among active duty service members. Are there numbers that you can share about that?
Well, we do know that testicular cancer is more common in active duty males than in the general population. We don't know entirely why that is. There's some theories and research going into it. Could it be environmental exposures that military members are exposed to? Um, is it just microplastics in the environment that everyone's exposed to? But military members have that access to care that they can go seek help, or we have mandatory appointments every year that you have to go see somebody. And so just by increasing the screening and people getting exams, we find it more. Um, but there's certainly a suspicion. We know career fields in general have a higher likelihood, like firefighters and aviators, people that work in submarines. Is it, something in their job that they're exposed to? We don't know, but we're aggressively trying to research that.
What does the research process look like? Are you asking these patients where have you been? What have you done? Or do you know, like through the military, okay, they were deployed on a submarine and there's these, things that they could have come in contact with?
Both. We know from their career field in the military what they do. But every new patient that we see, we've got an extensive intake form that's like 5 pages that talks all about their history and their exposures, and if they were deployed, when they were deployed, where they were deployed, for how long, what's their smoking history, everything about their fertility status, where they live, so we can collect that data, and then we can start trying to find an association with certain people or certain exposures and why they had cancer, and then trying to compare that to people that don't have cancer to see if there's any differences.
How long does it typically take in research to kind of find a pattern that could indicate that it is a potential cause?
Decades. Unfortunately, the more rare a event is, the longer it takes for us to figure out what causes that event and figure out how that's different than everyone else. And I when people ask me that, I kind of liken it to Agent Orange. It took decades for us to realize that Agent Orange increases the risks of certain cancers. And they're still trying to define which cancers can be caused by Agent Orange and what is just a coincidence that they had Agent Orange exposure. And they also have cancer that maybe they would have had anyways without having Agent Orange exposure. So I suspect it's going to be a long time before we can really point to say, hey, you are exposed to this at this point in your career, and that's maybe why you had testicular cancer.
Gotcha. Okay.
But I think the important thing is if we're not collecting the data and we don't have a efforts to figure this out, then it's not going to get done.
Gotcha. All right. So if there's a retired or active duty military member who develops testicular cancer and they're not stationed anywhere on a base and they're just, I don't know, in the Midwest or something, like how do they get in contact with you and make sure they're receiving the best care?
Well, they can always look me up through the military email, or you could just Google, Uniform Services University, and I have a page right there through the Department of Surgery, and you can email me through that, or you could talk to your doctor, and they say, hey, there's a doctor at Walter Reed. This is his name, and anyone can communicate with me. And the nice thing is about the military is it's big, it's global, but we know a lot. There's less than 150 military urologists, and we all know each other or know of each other, and it's easy to communicate one way back and forth, so we can, really consult each other. Or if one person has a patient that's going to be stationed at somewhere else, we can easily call them and say, hey, this guy's coming out to see you. Do you mind catching up with them and picking up his care? So it's pretty nice that we're connected in the military. So even if someone is in a remote location that doesn't have a urologist, that primary care physician or physician extender can always get a hold of a urologist, and that can get a hold of me or any other urologic oncologist in the military.
Is there anything else about the TESTIS program that I didn't ask that you want to share? Before my last question is going to be, again, just how does your experience impact your care?
Yeah, I mean, I think the important thing is that anyone can take away from my message, whether you're a military, VA, civilian, our audience is a lot of civilian, is you want to be treated in a multidisciplinary fashion. So that involves, speaking to somebody about fertility, speaking to somebody about the option of chemotherapy, speaking to someone about the option of surgery, also being counseled on surveillance, which is very important. We've got to keep in mind that patients often want to rush to treatment, but treatment has risks and side effects that, with testicular cancer, people are going to be living 50, 60 years, and we need to be mindful of those side effects and try to minimize the treatment toxicity. And so you want to have somebody that's comfortable with the disease, that is a center of excellence. And I think everyone is willing to consult somebody and to have a collaborative relationship with. And so if you feel like your urologist or your medical oncologist might not have the experience, maybe ask, hey, who do you think we could call for a second opinion? And really feel comfortable with the decisions that you make.
Awesome. And how does your experience with testicular cancer impact your the way you guide your patients in their decision making, or do you really let them take the wheel?
I look at it as it's my job to explain to them in a clear fashion what the situation is and what their options are and the risks and benefits of every option. I think that if they're confused, then I have not done a good enough job explaining to them. And then I tell them, like, hey, everyone has a different story. Everyone has different anxieties, but I'm also a testicular cancer patient, and I'm happy to tell you my story if you feel like that will help you. And, if they say, yeah, and then I talk to them about what I went through and how I experienced things through chemo and what I felt and how I managed those feelings and what I could do physically, how long it took me to recover it. And that might help them. But I try not to impart too much of like the patient aspects into that care, because everybody's different. But from my experience, things that I really focus more on is making sure that the patient's caregiver is involved in that, process. If somebody thinks they can just kind of handle this on their own, I really make a point of saying it's really important that your caregiver, your support system is there at these appointments or is there virtually when we talk, because most of the discussion is to them because they're writing notes and they're remembering things. And the patient has so much swirling in their mind, just like me, that you might not even be listening to everything. And, I'm trained in this. I know all the data and the research, but I still had my wife writing down the notes so I could focus on other things. And so that's really something I try to stress. I really stress the importance of behavioral health. We know that you are more likely to die of suicide with testicular cancer than you are to die from testicular cancer. And so every new person, they get behavioral health screening. And I say, hey, if you don't need it, totally fine. But at least it's worth meeting with them once and getting their contact information. And if you feel like you're having thoughts and feelings like you need help, then you at least have that go-to person. That is something I really stress that I probably didn't stress beforehand. And then I really try to be cognizant now of all the little things that you might take for granted or maybe not think about as a doctor, as far as like how many blood tests somebody's getting, or, trying to minimize all the different things that they have to go through. So if you need to get a chest x-ray and a CT scan, really try to coordinate that on the same day. So you're not making all these different appointments. So it's not creating all this anxiety in your mind. So you're not having to take extra time off of work, or really coordinating your tumor markers with other things like your testosterone and things, trying to order those at the same time. So it really minimizes what people are having to go through, because the disease is a lot to try to focus on. And the last thing you want to do is figuring out where to go, what time to get your blood tests, what days to get your blood tests, how do I get sperm banking, how do I get the financial paperwork done, all of that stuff. I probably wasn't cognizant of. And if I think I did, I know I'm definitely better at it now as a patient.
Amazing answer. Dr. Kern, thank you so much for being on It Takes Both.
Again, Stephen, thank you for doing this. Thank you for everything you've done for the patients and for me. And I really appreciate the opportunity.
For more information and resources for your testicular cancer journey, visit testicularcancerawarenessfoundation.org. You can also follow us on social media at TESTIS Cancer. We're on Facebook at Testicular Cancer Awareness Foundation.